also they introduced the anti-deaminated gliadin peptide. It's very useful for patients below the age of 2 years, for the group, child group, to confirm the diagnosis. So the initial step, when we perform, if we do tissue transglutaminase and total IgA, if the total IgA is normal and the tissue transglutaminase IgA antibodies are positive, we don't need to do anything more. This is a presumptive celiac disease. However, if it is negative or normal, low, negative, we have to go for other tests like tissue transglutaminase IgG, deaminated peptide, IgA, and IgG. Why this is important? Because we have to address certain things to confirm the tissue transglutaminase antibody specificity, to identify patients who have with celiac disease who have IgA deficiency, and to identify celiac disease in children below the age of 2 years. So now we come to our diagnosis. We have the symptoms, we have the blood serology, we go for biopsy. This is the gold standard. We go for biopsy and we find the villus atrophy. However, we have to understand that the child should be on gluten diet or the patient for a long time. If they are not on gluten, the biopsy will not give us any, or the serology will not give us any information. However, the question is, do we always need biopsy for celiac disease in children? Let's look at the European Society of Pediatric Gastroenterology, Hepatology and Nutrition Guidelines 2020 for celiac disease. They said the no biopsy approach for celiac disease diagnosis is safe in children with condition if the titer of the tissue transglutaminase IgA is above 10 times the upper limit of normal, and we do another titer to confirm it is high, and with this titer we do endomysial antibodies and it becomes positive. There is no need to do biopsy at all. This is confirmed. Don't send to gastroenterology, start treatment. Children with positive IgA tissue transglutaminase below the titer of 10 times the upper limit, they need biopsy because to decrease the risk of false positive diagnosis. This was 2020. What else in 2020? The high-risk groups for celiac disease, we should start the screening with the HLA DQ2 and DQ8 if available. If you can afford it, if in the country or on the hospital where you are following up, it is available, do it. Why? Remember Down syndrome, diabetes, we will be screening them on yearly basis to do the test, the tissue transglutaminase. However, if we know that these patients, they don't have the genes, we know that it is a good negative predictive index, no more testing needed. And again, these are the autoimmune and non-autoimmune condition that we need to do HLA if it is available. So we come to our treatment. We diagnose celiac disease, we are happy, so we come to our treatment. What is the treatment? We give them a prescription and it's written gluten-free diet, and it is lifelong. No wheat, no rye, no barley, even contamination. And the dietary threshold to promote healing of the intestinal inflammation should be less than 50 grams of gluten per day. Even some sources, they said less than 10 milligrams. So we have to read our labels very carefully. We have a specialized dietitian to follow with the patients. And we expect the improvement to happen within weeks, not immediately. And we follow this patient by the tissue transglutaminase titers. These are some of the celiac, the gluten-free diet products. They look very nice, looks encouraging. Even this guy is eating with a great appetite. However, there are disadvantages. That's why we have non-compliance to gluten-free diet. One is the cost availability. 2, poor palatability. 3, poor nutritional counseling. 4, poor follow-up. 5, poor 6, social-cultural effect. 7, peer pressures. They tell you eat, try. And 7 and last, transition to adolescent. They become rebellion. He wants to eat like everybody. He wants to try. So that's why it is very important to understand these points and to follow closely. And if we look at the cost as an example, it's almost double the cost for one person of a normal gluten diet. Now, if the family wants to join this child in terms of encouraging, the price will go higher and higher. So this is a really issue. That's why we need novel treatment. What else can we do? Should he be on lifelong gluten-free diet? And we said gluten is the beauty, is the taste, is the texture. Remember our pathophysiology. And depending on that, the researchers were working on certain options. Number one option is enzyme supplementation for degradation of gliadin. 2, correction of intestinal barrier against gluten entry by producing a zonulin inhibitor. 3, to block or to inhibit the tissue glutaminase from deamidating the peptide and make it more antigenic. 3, blocking of gliadin presentation to HLA system. Let's look at some options and what were the results. They started with the enzyme. They take the latiglutinase enzyme derived from bacteria and cereals, and they used it for non-responsive celiac disease plus the gluten-free diet. The treatment didn't achieve the primary outcome, which was the histological improvement of the intestine, and when compared with placebo, there was no really significant improvement in the symptom scores. So they might still use it, but really not promising. The second one was zonulin inhibitor. They started the study. They thought, let's prevent the opening of the tight junction induced by multiple stimuli like cytokines, bacterial antigens, and gluten fragments. And now in August 2019, they started the first patient on phase 3 clinical trial. We're still waiting for the results. We need more patients to be recruited, and we need. So we're still waiting, and the other issue that will be an adjunct treatment for patients with celiac disease, not a cure. But there is hope. Always, when we try, when we work, when we don't give up, there will be hope. And this was published in 2020. Despite the coronavirus, the bad news, the things are happening, still we are getting good news. So the treatment involves to give the patient encapsulating gliadin molecule in a small, very small, they call it gliadin nanoparticles, very small, to give it to the patient in capsules. And they found that the immune system, the T lymphocyte or the antigen presenting cells, they treated it like a harmless debris. They go and they think it is harmless, they accept it. And they send the immune system only just to clean it up. So this is really very important because we are reprogramming the immune system to tolerate gluten. And this can be a real cure. We can eat gluten, we can be happy. But what about genetically modified gluten? Some thought, why to do all this process? Let's think about changing the gluten and remove the gliadin from this protein, from this storage. So because the bad boy reputation of gluten has created, as we said, a new market opportunity for gluten-free diet. Not only the disadvantages that I mentioned, but these gluten-free, they are higher in fat, they are higher in salt, in carbohydrates such as sugars. Also, when we remove the whole grain, you have less fiber in the diet. And this will cause to have more serious problems like constipation, cancers, and other problems. So gluten-free diet is not heaven as we thought before. So now they are trying to create a celiac-friendly gluten, and maybe it will be in the horizon in the future. This was also in 2020. So before I end my story, I would like to share with you one message. Our greatest weakness lies in giving up. The most certain way to succeed is always to try just one more time. Winners never quit, and quitters never win. With vibes, we are all winners. Thank you.
And when he asked me to speak about persistent and chronic diarrhea, it was very confusing because telling in 40 minutes what is written in a textbook is very problematic. And I remembered a joke when a group of friends gathered together for a food, and they asked one of them to tell them the story of Moses alayhi salam, and he spent all the night telling without any food. And in the next time, he asked them to tell the story of Joseph alayhi salam, and they said nothing. A child was lost and then was found. Thank you. So I'm trying to put myself between the story of Moses and the story of Joseph. Uh, so I would be happy if you can tolerate this. We are going to have this definition because behind definitions, many problems are hidden. As you know, diarrhea, you should have the criteria of frequency, consistency, and volume as well. And to tell it is an acute one, it should be of acute onset. This is very important. The onset should be acute and should vanish and disappear within 2 weeks. And the episode of diarrhea, if didn't disappear within of this acute diarrhea within 2 weeks, this is persistent diarrhea. On the other hand, chronic diarrhea means something that started insidiously. So the mother cannot define the exact time at which diarrhea started. And there is a very wide range from 2 weeks, 3 weeks, 4 weeks, 2 months, but the most accepted is 1 month duration to define chronic diarrhea. And in spite of all these definitions, I tested when patients came for chronic diarrhea diagnosis. I found the mean duration was 3 months. So even definitions, when they are there, patients are not very sticky to the definitions to come to you. Let us start with this persistent diarrhea that was previously called post-enteritis disorder, with its etiology similar to the acute one, whether viral, bacterial, parasitic, and all viral causes of acute gastroenteritis are the same causes of persistent diarrhea, whether viral or bacterial causes, a list, or parasitic conditions or infestations. And the question will be, then why these persons failed to respond within 2 weeks and the others succeeded? And here, the factors favoring persistence. Number one, antibiotic use. If you use an antibiotic, you increase the chance of persistence. If your nutrition is not good, nutrition of the patient is not good, defective nutrition will enhance persistence. If there is underlying food allergy, persistence will occur. If gut peptides are released non-balanced, it can increase the persistence. Excessive cytokines, toxic bile salts, and small bowel bacterial overgrowth are among many studied risk factors for persistence. And here in this very complex diagram, I can go through the process that started with the infection, for which an antibiotic was used wrongly, with cytokines that are released, and these antibiotics can disturb the flora with dysbiosis, with decreased immunity, with more bacteria in the small intestine, small bowel bacterial overgrowth or small intestinal bacterial overgrowth that lead to abnormal bile salts. All these, in addition to the malnutrition, defective gut peptides, and allergic possibility of macromolecules, you are going to lead to persistent villus damage. And here the process will start with this persistent villus damage, leading to persistence of the diarrhea even after disappearance of the causative agent. And this persistent diarrhea can lead to malabsorption. And again, this malabsorption can lead to malnutrition, and a vicious circle is settled And if you are going to stop this vicious circle, you need to stop at different points of this diagram. So the ultimate clinical presentation of persistent diarrhea will be persistent diarrhea malnutrition syndrome. And the diagnosis is clinically done. It does not need many investigations. And the stool analysis may show the same causes or may not show anything. Electrolytes and acid base should be assessed because this is the same like an acute diarrhea. Assess nutritional status as well. Treatment is very problematic, and treatment of the cause will not resolve the persistent diarrhea. Many publications about probiotic therapy with different strains in cases with persistent diarrhea, nutritional manipulation, and the best of which is breast milk. Modified formulae may help in this issue, whether by decreasing the lactose or by making it hypoallergenic, partially hydrolyzed, or even using an elementary diet, or using a plant-derived food preparations. All these manipulations may succeed, and actually a doctor should be like a tailor who is aware to which case he can use which type. Method of food administration may help, and sometimes in severe conditions with persistent diarrhea, we may resort to gavage feeding, whether in a small boluses or in a continuous drip. And my previous research showed that continued drip for at least a few days through a gavage is very helpful in these conditions. Let us move to chronic diarrhea. And actually, it's a great problem. And we can classify according to the onset of the disease, whether it started in the neonatal period or post-neonatal. And in the neonatal time, we have different diseases that can start in the neonatal period. But first of all, before thinking in neonatal etiology of chronic diarrhea, you should assess first that it is diarrhea. And in many cases coming to me with this presentation of chronic diarrhea, it's clear that it is a gastrocolic reflex that is not a chronic state of diarrhea. However, if it is diarrhea, and according to Berging rate, you found that there are great loss of stool, and you have different problems in addition to the diarrheal definition, you have this microvillus inclusion disease. And this is either congenital that starts in the neonatal period. However, common presentation may start after 1 to 2 months of life. And this is called late onset, with prognosis being drastic and bad in congenital type that starts in the neonatal period and may ultimately ends into dehydration and death. Males are somewhat more affected, and among the cases I see, the males are still having a little bit predominance, 60 to 40. More than half of the infants are preterm. So if you have this preterm person, put in mind the possibility of microvillus inclusion disease. Before the age of 9 months, 3/4 will die. And diagnosis need histology. And if you don't have the electron microscopy, ask your histopathologist to test by periodic SHF staining. And if you didn't ask for this stain, you may miss the diagnosis. One of the very important points when you receive the staining of the biopsies, you will find abnormal staining at the upper part of the crypt cells or lower part of the crypt cells. If you found it in the upper part, this is a congenital microvillus inclusion disease. And if staining in the lower part of the cells of the crypts, this is a late onset disease that may survive with you. Treatment is easy peasy lemon squeezy. Death is expected, and we use parenteral nutrition and sometimes enteral nutrition may be used in some of the cases, and in late onset, they start to tolerate some of the enteral feeds in addition to partial parenteral nutrition. Before the age of 3 years, you don't expect to have, even in the late onset type, a survivor.